Um, Good morning or good afternoon. Um, I'd like to thank the organizers of this program for inviting me. I only regret that I'm not able to be there in person in Prague. I'd like to talk to you today about the anesthetic management for breast cancer surgeries and the development of what is known as an EROS protocol, which I will explain as we go along. I have nothing to disclose, but I would like to acknowledge my colleagues who participated with me in one of the studies that I will be presenting here. As we know, breast cancer is the most frequent cancer in women. Treatments include chemotherapy, endocrine therapy, and radiation therapy, as well as surgical removal of the tumor. Surgery and anesthesia may induce neuroendocrine, metabolic, and cytokine responses that lead to stress responses, inhibition of immune function, and can lead to chronic pain. It's known that 670,000 deaths occurred globally in 2022 from breast cancer. Despite primary treatment, between 6% of patients with localized tumors and 22% with nodal extension will still face recurrence at 5 years. Many studies have been reported on the management of breast cancer, but very few dealing with the role of anesthesia in the incidence of chronic pain following mastectomy surgery and the incidence of recurrence. So the question is, how does anesthetic management affect intraoperative nociception, postoperative pain, utilization of postoperative opioids, postoperative nausea and vomiting, long-term opioid use and dependence, the incidence of tumor recurrence, and the development of chronic pain? Evidence suggests that anesthesia itself may contribute to distance spread. Anesthetic drugs seem to interfere directly with tumor cell biology and to decrease natural killer cell cytotoxic activity, which plays a critical role in tumor cell destruction and tumor growth, as well as chronic pain. In this reported retrospective analysis, it showed that paravertebral nerve blocks, in addition to the anesthesia and analgesia for breast cancer surgery, with utilizing intravenous propofol for the general anesthesia, reduced the risk of recurrence or metastasis during the initial years of follow-up by about 75%. Unfortunately, the results of this study have not been confirmed in newer meta-analyses. In a randomized controlled trial investigating the effect of anesthesia as an independent prognostic factor for breast cancer, there was no difference between inhalation and intravenous anesthesia with respect to circulating tumor cell counts over time. However, in this study, regional anesthesia and preoperative medications were not used in the anesthesia management of this study. Acute pain suppresses natural killer cell activity. Optimizing postoperative pain management may attenuate the post-surgical inhibition of host anti-tumor defense mechanisms, including of natural killer cells. This has been demonstrated in a rat model and others. The potential or the potentially deleterious effects of acute pain are very difficult to separate from the effects of opioids. One conclusion is that opioids improve in vivo cancer resistance only in the setting of postoperative pain, and that opioids given under basal conditions can be immune suppressive and pro-metastatic. This diagram shows the two ways in which morphine may affect cancer cells. It can be pro-cancer or it can be anti-cancer, depending on the circumstances. Ketamine is one of the agents that we use in anesthesia, and intraoperative administration significantly inhibits the early postoperative interleukin-6 inflammatory response. And ketamine is a known antagonist of the NMDA receptor in the spinal cord, which when activated sets off the process of wind-up, leading to central sensitization and neuropathic pain. In this study, the conclusions showed that the data support a positive effect of ketorolac administered preoperatively for breast cancer surgery. These data are consistent with previous animal and human preclinical studies that suggested an anti-cancer effect of preoperatively administered non-steroidal anti-inflammatory medications. Celecoxib, a specific COX-2 inhibitor, is a better pre-op anti-inflammatory medication than the non-specific anti-inflammatories. This is an older study that followed patients over almost a 20-year period, and looked at preoperative factors, intraoperative factors, and postoperative factors that resulted in chronic pain. And it showed that preoperative pain, as well as postoperative pain, can be predisposing factors for patients developing chronic pain. Of course, the surgical approach and the risk of nerve damage, as well as anesthesia, was really not considered in this study. We know that when a surgical incision is made, a host of bad things happen. There's an enormous inflammatory response, and the receptors in the tissues are multiple. And we don't have any agents that can block all receptors at the same time. We do know that opioids can inhibit transmission of activated receptors, that local anesthetics can inhibit, and anti-inflammatories can. But when these medications wear off, or the nerve block wears off, these receptor sites are still active and can begin transmitting to the spinal cord once again. Regional anesthesia is known to prevent or attenuate the surgical stress response, blocking afferent neural transmission, and this prevents noxious afferent input from reaching the central nervous system. Paravertebral nerve block anesthesia and analgesia and or erector spinae nerve blocks are examples of regional anesthesia that are appropriate for breast surgery. They can reduce the need for opioids, which also impair the immune function, as we've already stated. Inhibiting surgical stress might attenuate perioperative factors that enhance tumor growth, tumor spread, and postoperative inflammation and pain. Today we now have portable ultrasound machines that we use to perform paravertebral nerve blocks and erector spinae nerve blocks. It has made these procedures safe and quite easy to train anesthesiologists in performing these blocks. This is the image that we see on ultrasound, and you can see the yellow lines indicating our targets for the paravertebral nerve block and for the erector spinae nerve block. We identify the pleura, the lung, the transverse process of the spinal vertebrae, and it becomes quite safe and easy to perform. And we've also been able to find that the paravertebral space is contiguous along the spine, and with a single injection site at approximately T5 or T6 level, we can block almost the entire chest wall on one side. If we move up to the T2 level and perform an erector spinae block, we can also cover analgesia for the axillary node dissection. If a reparative and reconstructive transabdominal muscle flap is also planned, we can perform another block called a quadratus lumborum nerve block, again with ultrasound, and this is a little bit more difficult to learn, but the landmarks are quite easily visible with a good ultrasound manipulation. And we can see between the quadratus lumborum muscle and the psoas major muscle, visualizing the transverse process and the vertebral body, our target would be between the QL and the PM. So now I'd like to move on to the development of an EROS protocol, which is called Enhanced Recovery After Surgery. This is utilized around the world for many different types of procedures, but there was not one specifically for breast cancers. In our protocol, all patients were seen in the surgical clinic prior to surgery, given information about not only the surgery, but the anesthetic nerve block that is recommended for better pain control. All patients were also seen in a pre-op anesthesia clinic, and the anesthesia management was explained, including details of the paravertebral nerve block. This was able to relieve anxiety at the time of surgery and enhance the efficiency of getting the anesthesia consent for the nerve block and for the general anesthesia. Our protocol included pre-op oral medications, gabapentin, at least 300 milligrams, acetaminophen, 1,000 milligrams, and celecoxib, 200 milligrams orally. When in preparation for the nerve block itself, 1 to 2 milligrams of midazolam intravenously was administered for sedation if the patient needed it. The patient was placed prone, and then the paravertebral nerve block was performed using 0.5% ropivacaine, and the volume depended on the size of the patient, as well as whether we were doing bilateral or unilateral. And currently, we added the erector spinae block in order to block the axillary node dissection if that was planned. In our original paper, we did not include those patients. Anesthesia induction then was performed with a small dose of ketamine, 10 to 20 milligrams to block the NMDA receptors, as I mentioned, propofol and fentanyl as needed, and a muscle relaxant for intubation. The general anesthesia in most cases was maintained with half sevoflurane and half intravenous propofol. After induction, but before surgical incision, 2 grams of magnesium sulfate were administered intravenously slowly over around 2 to 3 minutes. Additional fentanyl, as indicated, or ketamine was administered as needed throughout the case. Dexamethasone, approximately 4 milligrams, was administered as part of the antiemetic protocol. All surgeries were performed by the same surgeon at the same institution between July 2016 and February 2018 with this protocol. The records were analyzed under an IRB-approved retrospective study, and the patients having partial mastectomy were excluded, and there were several other exclusions, leaving us with 124 patients that were completely analyzed. I'm not going to go through all of the collected demographics, but it was extensive. We also looked at comorbidities, the most representative being hypertension, gastroesophageal reflux disease, diabetes, thyroid, lung disease, anxiety and depression, and chronic pain as well. Preoperative evaluation also included a history of tobacco or alcohol use or illicit drug use, and included the use of things like marijuana and chronic opioid use. Data on other medications like nonsteroidal anti-inflammatories, gabapentin, celecoxib, acetaminophen, beta blockers, etc. were also noted. Histological type of cancer and grade biomarker patterns were also noted, and whether the patients had had chemotherapy or anti-estrogen therapy or radiological therapy prior to the surgical intervention. The surgical procedures were total mastectomy with or without sentinel or axillary lymphadenectomy, or radical mastectomies. We looked at the postoperative data, particularly the pain scores in the first 24 hours after operation. Most of our patients were routinely discharged from the hospital on postoperative day 1. Pain scores were graded, and the incidence of postoperative nausea and vomiting was measured as well. We looked at the postoperative opioid administration expressed in morphine milligram equivalents, and that usually correlated with the amount of nausea and vomiting treatment. We registered all pain medications prescribed on discharge, the most common being a hydrocodone-acetaminophen combination, or in some cases morphine, oxycodone, or tramadol. And we also noted prescriptions for gabapentin and NSAIDs. Follow-up data was obtained in the surgical clinic at week 1, 1 month, 6 months, and 1 year after the mastectomy surgery. And during every encounter, we recorded the presence or absence of pain, recurrence of new metastases, reoperations, depression, incidence of complications like seroma, infection, or dehiscence of the surgical wound, impairment of the brachial plexus, including neurogenic pain, changes to pinprick sensation, and other alterations of motility or sensibility in nerve distribution areas. The immediate postoperative pain scores in the post-anesthesia care unit was 1.3 on the 10-point scale, where 10 is the worst possible pain you could imagine. Severe pain occurred in about 19% of our patients, and the average total dose of opioids administered to patients postoperatively in the first 24 hours was about 10.4 milligrams of morphine milligram equivalents. And this included the opioids administered in the post-anesthesia care unit. Postoperative nausea and vomiting only occurred in about 10 patients, or 8% of our patients, and the incidence of chronic pain after mastectomy was 16.7% at 6 months, and only 13% of the patients had chronic pain at 1 year, with the reported incidence of preoperative pain, which was 31% of our patients. The overall satisfaction with the combination of surgery and anesthetic management reached 96% in our patient population. In conclusion, the only statistically significant associations between severe postoperative pain was with a preoperative history of alcohol consumption or a preoperative history of opioid use. Anesthetic management influenced not just acute postoperative pain, but also seemed to have decreased the incidence of chronic pain in patients having mastectomy surgery for breast cancer, with the incidence of chronic pain at 1 year was only 13%, despite the prevalence preoperatively of almost 32% of the patients. It's not possible to draw any conclusion from our study about cancer recurrence, but we hope to look at the data now more than 5 years out and see if there was an effect on cancer recurrence. A careful history of preoperative use of opioids for chronic pain or alcohol consumption, independent from the type of breast cancer, staging, markers, or pre-surgery therapies, should alert the surgeons and anesthesiologists to patients at greater risk of chronic pain development post-mastectomy surgery. It is possible to reduce the risk of post-mastectomy chronic pain with a comprehensive and coordinated Eros anesthesia and surgical protocol. Voltaire said, "Doctors pour drugs of which they know little to cure diseases of which they know less into humans of which they know nothing." And Einstein said, "We can't solve problems using the same kind of thinking we used when we created them." And so what I would just like to impart is that we need to open our minds to not just looking at one type of therapy, whether it's endocrine therapy or chemotherapy or radiation therapy or surgical therapy, but a lot of these procedures require the anesthesiologist to be intimately involved, and we can significantly influence the outcome of these other types of therapy. And with that, I would take any questions. Thank you very much.